brain injury in general is really common. According to the Brain Injury Association of America, about 1 in 4 people in the US have experienced a brain injury during their lifetime. I think especially people our age and older, you think about, we used to say things like, oh, he got his bell rung, oh, but he's
Mhm.
okay, walk it off, that kind of thing. That was a brain injury.
These MOs are not stable. They're not sleeping, right? Their sleep is disrupted. They have pain that's not managed. They had pre-existing substance abuse histories, and now maybe they were significant. Now they're dealing with cravings, and they're managing cravings. Maybe they have something called a vestibular disorder, which is when you fall and you have these sort of like little tiny crystals deep in your inner ear canal that regulate your proprioception and your sensory perception. Those get disrupted in falls and sort of traumatic brain injuries. Now you feel like you're like on a boat, or you're seasick, or you're drunk and spinning. That's how it's been described to me. So if you're feeling any or one or more of those things, guess what? Like, all the stuff I think is important is not important to them.
All right. Hey, everybody. Welcome to another episode of Cooperant Learning. I'm really excited about this one. I'm Kyle Steary, your host. With me, as always, is Steve Sparks. Steve, how are you right now? What's going on?
I'm just getting chomping a bit ready to head to ABAI next week. I see that you have your hitchhiker's thumb prepped, ready to go for your trip
I
out
didn't know
there
if
as
you're
well.
going to call that out. Yeah, I'll spare
Yeah.
everybody the details. It was an incident with a can opener, and I'll leave it at that. The baked beans were fine though, and we had the barbecue, but not without a little bit of insult to injury too. So.
He's just going to make it that much easier to find a ride all the way out there to Cali, so we'll be just fine.
Oh man, I do. So this is beyond the scope of this episode. I do have some funny hitchhiking stories from my vagabond band days, but I'll spare you those right now because we have some awesome guests.
The Douglas Adams sort, yeah.
Yeah. Yeah, oh man, I could do a whole podcast on that book. That'd be great.
Yeah.
But hey, we're hearing some of our guests already. Let's go ahead and get them introduced. And we're talking about traumatic brain injury today. I'm really excited about this one. So our first guest holds a master's in special education from Temple University and a PhD in psychology from the University of Nevada, Reno. Her work exploring the relationship between behavior and various physiological conditions through interdisciplinary collaborations with experts in fields like biomedicine, pharmacology, and reproductive endocrinology have been published in a wide array of journals, including the Psychological Record, Behavioral Processes, JAB, Mexican Journal of Behavior Analysis, and Human Reproduction. She has co-authored several publications on the application of behavior analysis towards the treatment of brain injuries, including a chapter for the Essential Brain Injury Guide 4th and 5th editions, director of the online Masters in ABA program at University of Utah, and serving on the chair for ABAI's Brain Injury SIG Research Subcommittee. Christina Peters, thanks so much for joining us today.
Yeah, thanks for having me.
Joining her, our second guest has worked in post-acute brain injury rehabilitation since 1995, focused on neurobehavioral programming for individuals with all levels of impairment. After earning his master's degree from Temple University, he spent 20 years as the BCBA within an interdisciplinary team, working in an intensive neurobehavioral setting for adults with acquired brain injuries. He's the current president of the Brain Injury SIG at ABAI. He's co-authored chapter the neurobehavioral complications alongside Dr. Peters, and national behavior analyst with Collage Rehabilitation Partners, Christopher Schaub. Thanks so much for joining us.
Thanks, Scott. You can call me Chris.
Yeah.
My mom only calls me Christopher when I'm in trouble, so that's cool by me.
Gotcha. Well, you're not in trouble, so I'll tailor to that. We're both really excited to discuss this topic with you, especially just given the depth of your experience in this particular field. Do you mind just opening up? And Christina, we'll start with you. Just a little bit about yourself and what led to your interest in acquired brain injury treatment.
Absolutely. So, our stories are sort of intertwined. So I have to say that Chris is really who got me into and inspired to do brain injury work. But, like so many of my generation forward, I got my start in autism treatment. A typical story, graduating college or graduating high school, some kid in the neighborhood had autism, looking for services. I was a good babysitter, But after doing that for a few years during my undergrad, I really wanted something different. And applying to schools, I was at the ABA Grad School Expo. I had committed to go to Temple. Phil Heinlein, who's been our mentor and friend for decades now and is an amazing human, said, hey, you're coming to Philly. You want something different. You have to meet Chris. And he introduced us at the grad school expo that year. And the rest is history. It changed my career. It changed my life in so many ways.
I hope someday, somewhere, somebody's like, you have to meet Kyle. I don't know that that's happened yet, but if that would happen, I'd feel really good about myself.
Usually, like, yeah, if you have to meet Kyle,
yeah,
that's
exactly.
how it usually goes.
But Chris, same question. What kind of got you into this field?
Well, it's a very different sort of pathway, but I'm so glad that I'm on it. I mean, I came out of undergrad with a degree in secondary education, political science, thinking about graduate school or teaching. And literally a guy I grew up with in the neighborhood had a BA in psych and was working at this, coming home when we were hanging out in the summer, he was telling stories about these guys that he was working with, these brain injured folks. And so I decided I wasn't clear about my direction next. So I'm like, whatever, I need a better job than I have right now. So I applied and got hired. And then I met the most inspiring people I think I've known my whole life. Fortunately, at this point, I met OTs and PTs and psychologists and moms and dads and brothers and sisters who were all trying to figure this brain injury thing out. And I came into a company in 1995 that was only 10 years old and was founded by a fellow who was working in sort of like a Bancroft, like large IDD environment. And in the 80s, the late 80s, when people were starting to survive brain injuries because of medical technology, they were finding themselves in these kinds of places because there was nowhere else for them to go after the hospitals. And so this guy that started Remed started there. And then he figured out, hey, some of these people are different. These people they had lives, they had skills, they had a sort of pathway and a history. So that became our version of neurorehabilitation for a company that's called Remed. That's based out of the Philadelphia region, essentially. Now in Maryland and Pennsylvania, it's much bigger than that. I'll talk about that later. But I came into this in after 10 years, and it was the most intensely passionate group of people. They were just so profoundly connected to the guys, to the mission, to whatever it took. And I wasn't even a behaviorist at that point. But I realized in my path that I think my interest in education and sort of poli-sci government theory side was really ultimately about human behavior, if you distilled it down. And then I met a behavior analyst by the name of Scott Helsinger, who showed me the ropes, and Rob Chittum, another guy. And then all of a sudden I was like, they're like, you got to meet Saul Axelrod. So I met Saul Axelrod, and Saul's like, you got to meet Phil Heinlein. And I met Phil Heinlein, and that was it. I mean, and then it just took off. I did my master's with Phil, and he so just serendipitously introduced me to Christina. And it just became this amazing, opportunity really to kind of stretch it all out and get started. And there was all kinds of latitude and a big broad canvas to work on. So it was just really inspiring from the beginning. The clinicians working with were experts and passionate, and the clients they were incredibly compelling stories and their families. And so that was the rest, as they say, is kind of history. That was January 1995. Here I am.
Wow. Yeah.
Yeah, and it's been about dissemination since then, Kyle, as you said, and Stephen, right? Getting it out to getting us in there and getting them to know us. So
Yeah, that company and this field, we've joked a lot though, in so many ways that there's a bit of Hotel California vibes. Like I came on to do a semester-long internship, which turned into 2 semesters, which turned into me taking the train and walking a mile and a half every day in the summer, which then turned into me putting off my PhD for 5 years. I mean, when you
Sure.
say inspiring people, you have no idea, the commitment and the energy. It's amazing.
and the first third of that was free, was unpaid.
Yeah.
it was for supervision hours.
Yeah. Remember
that's
what we
amazing.
used to do for supervision people.
Yeah, supervisees coming in with all these demands these days.
Teaching classes at Western as a grad student, I'm like, we are paying to do this because we're getting credit for it. So I'm actually paying to teach, not being paid to teach.
Well, I'm super excited to have this conversation. We grazed this topic. For one, this is a topic that I'm very unfamiliar with, so I'm excited to learn. We touched on this, I believe it was with our behavioral gerontology episode with Dr. Baker. And then had a conversation with Dr. Allison Cox, who was saying, "Oh, you guys grazed that. You really got to get the Chris on and Christina and really dive in." So we've had a few scheduling hiccups, but I'm glad this is finally happening. And let's dive into it. So, traumatic brain injury. What is kind of the overall, working definition of TBI, and what are some of the common symptoms of TBI? Like, what is the day to day life for somebody who has traumatic brain injury?
Yeah, absolutely. So, there's been a shift in terminology over the years, and not so much that the definitions have changed, but rather just the vernacular has changed. So, back in the day when I started out with Chris, we always talked about us working in TBI, and sometimes casually we still do. But ultimately, TBI, traumatic brain injury, is a specific type of acquired brain injury. So acquired brain injury is the umbrella term, and it's the term that we're all kind of moving towards using. But some habits die hard, so you'll probably notice as we talk, we're going to slip back and forth. But I'll start with acquired brain injury because that's the umbrella term. That is the term used to describe any damage to the brain that occurs after birth. So that can be both a traumatic cause or a non traumatic cause. Traumatic brain injury then falls under that umbrella. That is a brain injury that was caused by some sort of external force, so falls or accidents. It can be something very dramatic, like an impact, a blast. You see that kind of thing in soldiers, right? But also a lot of those things that we think of as more mundane. So a concussion, falls, motor vehicle accidents. Those all fall under the category of traumatic brain injury. You can have non-traumatic ABI, right? So non-traumatic acquired brain injury, and those are usually internal causes. So tumors, oxygen loss. So let's say somebody, for some reason, ends up underwater for some period of time, and they don't have oxygen. It can happen because of infections, because of strokes, aneurysms, meningitis. It can even be related to heart attacks. So, traditionally, brain injuries were subdivided it by severity. And I think, and Chris can jump in and correct me here, but I think we're kind of moving a little bit away from that in the community.
Yeah. They started with this very oversimplified, mild, moderate, severe classification system that's based on like the Glasgow Coma scale and Rancho Los Amigos. We go on into go into too much detail about those today, but suffice it to say, those were the rudimentary sort of diagnostic tools or assessment tools. And so they came out with this, which everybody bemoans now, is say this is because number one, there's nothing mild about a mild traumatic brain injury starting from the beginning. You could be classified as
Mm,
mild because, as Christina said, you fall and have a concussion, you go into the ER, there's no blood, no bleeding, no swelling, you seem fine. So you go home, or you don't even go to the ER and you go home. But then the next thing you know, 2, 3 days later, you might have these persisting kinds of symptoms or headaches or difficulty with information or light or noise. And all of those things could infer there's been some sort of damage that's been, but it's not visible on scans. So that's all, and that would all fit under the mild, which a large percentage of brain injuries are. And then mild and moderate and severe are just grossly in precise terms to describe the kind of care that people require, the kind of deficits that they might have, and the kind of incredible complexity associated with their case.
Yeah. And one thing that Chris brought up that I think is so important for us to understand is, what used to be called a mild brain injury is something that we call concussion. And, thankfully, there's a lot more information out there about concussion nowadays, but still, people don't understand how impactful a concussion is. And I think a lot of people don't understand that a concussion is a brain injury, period. So, brain injury in general is really common. According to the Brain Injury Association of America, about 1 in 4 people in the US have experienced a brain injury during their lifetime. And, I
uh,
think especially people our age and older, you think about, we used to say things like, oh, he got his bell rung, oh, but he's
mhm,
okay, walk it off, that kind of thing. That was a brain injury.
yeah.
In the US, someone will sustain a brain injury every 9 seconds, which is
Mm,
just crazy to consider. And the implications of brain injury are as unique as the individual that sustain them, really. But the main kind of categorizations, at least as the Brain Injury Association has them listed now, thinking and learning, physical health and communication, emotion and mood and behavior. And under each of those is a long kind of laundry list. So, thinking and learning, issues with concentration, issues with what professionally they call motivation. We would think of initiation of a task. People could be easily distracted. They might not be able to shift their attention. One really big thing is problems with awareness and particularly self awareness. So, there's a specific disorder associated with brain injury, amongst other things, but it's called agnosia. And it basically is a term that translates to like um, unaware. Now I'm going to, uh, 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 now I'm forgetting, unaware. But basically,
Unawareness or like inability to identify deficits. Yeah, like a
yeah,
blindness, almost like a blindness to deficits.
Okay. Okay.
Yeah.
absolutely. You'll have someone, and it's interesting. I did my master's thesis on this, and because it's a really interesting phenomenon. I mean, basically, people are unaware of their own deficits. So you'll have an individual who will stand up and fall down, and then they'll stand up and fall down, and then they'll stand up and fall down. And if you say to them like, "Hey, man, don't stand up without help," they'll get into an argument with you because they don't actually, non-behaviorally speaking here, speaking loosely, they don't understand that they're gonna fall down. Um, and that we could do a whole episode on that because just the psychology of that is really fascinating. But the implications of it for the individual can be terrible, right? Because if you don't understand that you can't drive a car and you get in a car to drive it, or you don't understand that you're not safe to be left at home alone, but then your family tries to have someone with you at all times, you become argumentative. You can become highly resistant. It causes a lot of problems, right?
Yeah.
Um,
People want to drive their cars, shoot their guns, mow their lawns, fix their roofs, and they can't, they shouldn't. But they look in the mirror and say, I'm fine. I'm walking, I'm talking. Sometimes even families members say, well, they look and sound like themselves. What's the big deal? And then as soon as they go to do any of these tasks, their other deficits are profoundly aware, at least to everyone else except them, or obvious rather to everyone else except them. And sometimes this feature, this kind of like anosognosia, this awareness deficit, and there's a little bit more detail we should go into later as it relates to prognosis and sort of the continuum of rehab, because sometimes this can be the singular issue that keeps somebody in a sort of safe setting rather than
Sure.
home. Because when they get home, and this just happened in a case I'm working on now, this guy went home and he's a large fella, over 6 foot tall, over 300 pounds, and he went home and asked for his truck keys, and his family said, can't have those. And he proceeded to break chairs
Hmm.
over his kitchen counter because he also had a pretty significant frontal lobe injury that involved poor frustration tolerance. So you have a large adult male dad, husband in a house, screaming, yelling, smashing chairs in a highly discontrolled way because he can't have his truck keys and he doesn't understand. And I don't know, we didn't talk about this beforehand, but his version is, why the fuck can't I drive? Right.
Yeah. Yeah.
So, and just give me the fucking keys and get the fuck out of my way. And I'm speaking intensely for a reason because that's what's happening in someone's kitchen or someone's living room. You're getting these people that don't understand why I can't do this. And then because they're also suffering from these other types of features of their injuries, they explode sometimes.
yeah,
And
Sure.
that's what you call neurobehavioral sequelae, ostensibly.
yeah. I think you kind of captured it all so well because under behavior you see impulsivity, you see poor judgment, you see emotion and mood changes. So people who are feel things more intensely than they have before, and on top of this they have physical and health problems, right? So they might be in pain, most likely, if not from the actual trauma or whatever it is that caused the injury or illness, but maybe just from a side effect of it. And so then you put all those things together and you have presentations like Chris said, or even, post acute or, in acute care settings when somebody really needs medical care. They might be pulling tubes out. I mean, we talk a lot with the folks at Craig Hospital in our research subcommittee, and they're always talking about interventions just to keep somebody in a bed and with their medical devices attached to them because you get the same presentation. Why am I here? Why is this tube here? So
Right.
you can only imagine how complicated it can get.
Right. And it really paints a picture of, like the anger, the frustration, the physical aggression, things like that might not necessarily be this injury happened, now they're aggressive. Like there's frustration, there's a misunderstanding of like why the environment's different now, like why people are putting these restrictive practices in place around me because I don't see a problem with what's going on,
Right.
but somebody else does. Sorry, Steve, were you going to say something?
I was just saying this is where our experience or my experience has always been with brain injury is, they've gone through the rehab process. Everybody says, all right, you're good to go. Set them out either on their own or in a group home. And then, all right, now the behavior issues are popping up. What do we do? And that's where they
Right.
call us in. And we're trying to,
Right.
figure out which skills aren't there that we can teach and address it that way as much as possible because the system as a whole just wants to restrict kind of thing.
Right. Well, and it's also, that's exactly right, Steve. That's all part of this, right? And what's lucky about the environments where, especially where Christina and I worked together, we were given a wide berth. Whereas, we had all these other experts, on the team, like OT, PT, speech, neuropsychology, drug and alcohol counselor, therapeutic recreation specialist. We had everybody at the table. And they all had expertise in their specific domains. But as even Christina mentioned earlier, and I've described, like a lot of them ran into resistance, which could just be like a lack of initiation, almost like this inertia that could be, you could be, sort of influenced by a vast number of variables. And we'll get to that in a little bit. The classic Phil Heinlein phrase of the inside and the outside story of behavior, right? Because in brain injury, we're supposed to come to the table as experts in the outside story. But boy, if you're going to work in brain injury and be effective at it, you got to get to know the inside story, really. And I don't mean to say homuncular causes of behavior, right? We're talking about inside story, like variables influencing behavior or that are behavior that we have to track somehow, because that's how you get at all of these things. But it's interesting because the beginning part of a, recovery, like there's some like terrible accident someone sustains. Like someone goes off, a couple people we've had, which are guys, I mean, I'm 54 years old. I have two 28-year-old kid. I've been married 26 years Wednesday. And all of a sudden a guy like me is driving home from work and has a cardiac arrest and my car goes off the road and my car goes into a tree. This is a guy we admitted 6 months ago. This is his story. 50-some-year-old guy, grown kids, stable life, good guy, coached his kids, that sort of neighborhood fella, whatever. And it's not gender specific, just guys tend to do a lot more dumb things or whatever anyway. The demographics are skewed towards males. So that'd probably be my sort of lean here by accident. But anyhow, and then everything's instantly different. And you go into, you're maybe like life vac out or medevac out to a trauma center, you get trauma care, you go through ICU, and you make your way through this linear progression of settings in a hospital, all the way through to, like, say, an acute rehab setting, which can have its share of, as Christina alluded to, Craig, its share of certainly behavioral complications, but they're managed very differently. I think that sort of hints at what you're saying, Steve. They're managed very differently in those settings. And then at the end of that acute care rehab, there's these really complicated what now, what next questions, like where does this person go? What kind of supports do they need? Are those supports even available in their hometown? And that's where we've sort of made our hay, is in this world of post-acute brain injury, like this idea of what happens after acute care. Now, some of us are trying to get into acute care hospitals, and luckily Craig's committed to that. And that's a terrific thing because there's a couple BCBAs working in there out in Colorado, which Craig's a big, for those that don't know, Craig is a highly specialized rehabilitation hospital in Englewood, Colorado. And it's one of the most well-known in the world for what it does in brain injury and spinal cord. So we're lucky to be proximal to them. We have an intensive neurobehavioral setting also in Lakewood for the organization I work with. We have settings across the country, and one of our intensive neurobehavioral ones happens to be 20 minutes from Craig. So it's this great connection between our post-acute BCBAs and theirs. But anyhow, sorry, swinging back around here, this idea of the care and the continuum of it is very much organized in the early stages. And then it becomes a battle around what resources or what funding is available. Like, how did somebody get hurt? Was it like we've treated contractors who were there? And I grew up with guys like this. They do their own work. They're not insured as a contractor. They just fix stuff. So they make money doing that. And then all of a sudden, one of these guys falls off a roof or a scaffolding or a ladder. And now they weren't hurt at work per se because they were working for themselves, and their private insurance isn't going to cover this kind of stuff. Sometimes it's beef and beer money. Sometimes, like in Pennsylvania, there's a head injury fund that people can get a one-time allotment of money to get rehab services. So that really profoundly affects, like, time and resources for people in their recovery. And regardless of what's going on, I mean, that's just things we have to be aware of. What we really do is zero in on the organism and try to get a handle on this inside story and outside story. And we'll get to that as we talk about the model, Kyle. I don't want to get too far ahead of things, but
Yeah,
how we start to organize those things behavior analytically. So I want to make sure Christina covered the definition the way that she wanted, and then how we go about this sort of care continuum first. Sorry, and then I'm just like eager.
You're good. You're good. I think that's a great. I think it's a great segue. So like you said, given the depth of different side effects, severity, the definition is kind of wide ranging. Is there a good operational definition as you look and do like a behavior analysis of TBI and acquired brain injury?
No. There isn't. So in
I
the
was
rehab
hoping you could
world,
have
there's a
one, and
saying.
then as you were describing everything, I was like, man, this is gonna be really tough.
We just put it in the chat. We just put it in the chat, Kyle. Right.
Yeah.
Right. It's complicated.
So, there's a saying, if you've met one person with a brain injury, you've met one person with a brain injury. And, I think to some other fields, it may seem strange that that's the case. But actually, if you bring it back within our science, it starts to make a lot of sense, right? The presentations are so varied because they are so contextually dependent. You think about our level of analysis. Our level of analysis is whole organism interaction with the environment. There are differences in presentation based on changes within the organism, on the pre-existing physiology of the organism, on the pre-existing psychology of the organism, and then the interaction with the environment. So, we've seen individuals who, were in, maybe special education from the start. They dropped out, they never graduated. They got into some sort of menial work, and that was their existence, and they were fine in that existence, but maybe marginally, maybe kind of got in trouble sometimes, use substances, et cetera, right? And then have an injury, and then they present in the hospital. We've also had individuals, we had a professor who was with us, right? Who had a very different existence prior to injury, then has an injury and now ends up, right? So there's different learning histories there. There's different physiology there. And so all of that matters in terms of then what you're seeing afterwards. And then, of course, all of that matters in terms too, if you think about, and there's more, some of our colleagues have become really interested in like, what is the environment immediately post-injury? So if somebody shows a lot of agitation immediately post-injury, are they going to be restrained? Are they going to be chemically restrained? Are they going to be physically restrained? Are they going to have access to a BCBA, which is only in a few situations? And then what kind of behaviors shape up after that, right? So for all of those reasons, because it's so contextually dependent, there's not a good, there's not a good definition. But I will say, as a behavior analyst, you get incredible practice at operationally defining behaviors because you see some wild topographies of behavior. And sometimes I still remember Chris and I spending hours kind of coming up with different either even just labels for target behaviors, or non-reality based statements accompanied with emotionality.
Yeah.
In other words, you've stolen my dog and he's on the roof again. I'm pregnant with 12 babies. Like that kind of thing. Like, how do you even define that as a behavior analyst, and how do you define it in a way that staff can then track it? So you get a lot of practice in that.
I was to say, my kind of the way I've always thought of why there's so much variability as well, and you can tell me if I'm way off the mark here. It's through our learning history and our learning process, there's almost a continuum of interconnectedness in all the stimuli in the environment and the associated behavior. And so if you have damage in one area, and then that's associated with something different from one person than another person, you're never going to have a real good presentation from one to the other because of all those different learning histories.
Oh my God.
Yeah, that's
absolutely.
exactly. And a colleague of mine, Steve, coined the term. Well, she used it around me, and I preferred it as disrupted operants. I mean, you have all these pre-existing relations, and now you've banged up the supercomputer that was organizing all those relations, right? And now the parts of the computer are maybe repairable, like through like a neuroplasticity or maybe even just early phase of recovery. Some folks are in active PTA. They're walking around, like Christina said, they're looking for their trucks. I had a guy, I was telling somebody the other day, for the first 2 months we treated him, he called me pastor because I looked like the pastor from his church, because he thought I was the pastor, not because I looked like this guy. It wasn't like a nickname thing. He was not understanding where he was. And then he would go sit in the van in the driveway and say, I need to go pick my kids up from school. It's 3:00. And it's like, wow, pal. And this is a guy who was teaching in a school who was hit on the side of a road power walking. Like, these are the kind of horrible stories that occur with, and this is how these relations, like boiling it, distilling it down to its like most principal roots, this is what happens. And then you have things like, not only are these relations disrupted, but now there's visual deficits, there's hearing deficits, there's processing there's just managing deficits with managing information or retaining information, right? And long-term versus short-term. And we're not going to get too deep into the organism, so to speak, but in terms of the inside story, we have to be able to understand. So things like a neuropsych eval to us become really important, because that tells us how the car's running. You know, are they processing information? Do they see, like, sometimes you'll walk into a dining room and there'll be a guy eating, you ask him how dinner is, and the entire left side of his plate is still full of food. And you say, oh, weren't you hungry? And they're like, why? I ate everything on my plate. It's like, oh, because they have a left field neglect and they don't see the left side of their plate. And you see them do a clock draw and they cram all the numbers into one side of the clock. It's like, okay, that's how this guy's seeing the world. You know, or some people they have perfectly fine vision, but they can't process what they're seeing. So you have all these different agnosias, these visual agnosias. They hold a pen up and say, oh, hand me the remote. And they grab your pen and they start trying to change the channel to the TV with your pen, because they're not organizing stimuli in their environment. So that's broken down. So a lot of the beginning of it, especially in the most complex cases, is doing this deep dive to try to figure out, meaning to say, like, exhaustive analysis or examination or assessments, right, of where these deficits are. And then trying to come back out to say, okay, so what's still there that we can lean into, what's teachable, and what do we have to compensate for, and those kinds of things.
Yeah. And
I mean, yeah,
there's
please,
there's
Christina.
there's the physiology, right? Like, just from a neurologist would say everyone's brain is organized differently, but to get back to what you were saying, Dr. Sparks, like, there's also, there's also the psychological differences. And, after discovering brain injury, I went to UNR, and with under the support of Dr. Linda Hayes, I learned about inner behaviorism and Cantorian approaches to things. And all of a sudden, like, this idea of substitute stimulation was like, oh, yeah. Oh, yeah. Like, their learning history is going to be so important and also so varied. And so then when you see these differences now that Chris is describing, of course it's going to be kind of a mess, right? Not a mess we can't get through, but a big puzzle for sure,
Mm. Yeah, I was reading over the chapter in your book, and you talk. I think this was post coma. That there's like you
Yeah.
reference like a period of time in which consequence based learning is not even really feasible or effective. And I was like, wait a second, I'm a behavior analyst. What do you mean consequence based learning isn't going
Right.
to work? Yeah, that's wild.
So you have to really have a handle on that, Kyle. Yeah, I was going to say, you have to. And I would say to people when I'm speaking to, especially the behavior analytic audience, I was to say, one of my favorite textbooks from graduate school was Catania's Learning. Like, so let's talk about behavior in terms of learn, because behavior gets used so misused colloquially, especially in he's behavioral, he's got behavior. It's like, I sure hope he does. Otherwise, we got a lot more work than so all that sort of just misunderstanding and all of those things. So let's just talk about learning and someone's capacity for learning as it pertains to their phase of recovery. And we have to treat that capacity for learning at every stage of recovery. And so, especially for frontline staff, like direct care staff who haven't had the opportunity for the kind of education or experience or mentorship that some of us have had, they come into a setting and a guy's yelling and screaming at them, because we had a guy who was from the Navy. He literally was out of the Navy working in construction. He was flat boat fishing somewhere out in Western PA for bass on a bank of a river, and a dead tree fell on him in the boat. And it looked like this
Wow.
doesn't, I mean, almost graphically, It looked like Wizard of Oz. The only thing you could see from the pictures that his mom had were his arms and legs, and his whole body was covered by this tree. And he sustained a horrific brain injury. And he would wake up now he went through a hospital course. When he came to us, he would wake up in the morning and say, "Who's in charge of this fucking boat? Like, this place is a mess. I want you to clean this and you to clean that." And this guy thought he was back in the Navy because the unit he was in had these kind of transom style windows. And he thought we were in some like below deck of a boat. And he's yelling at us to clean the boat because he thinks he's living in 20 years ago of his life. And so you take direct care staff like that, and they're getting screamed at by this tall man who also won't sit down in his wheelchair, and they're freaking out. And I'm in there like, okay, here's what we're going to do. We're going to roll with it. We're say, hey, we're going to get to that. Let's do this first. We just live in their reality. And then we're talking to them about, this is a phase of recovery. Might take management of sleep. It might take management of medications. It might take just natural healing processes like swelling and bleeding to resolve. But we have to keep this person safe until their ability to learn becomes more consistent. Right now, you can't teach a guy that thinks he's in a boat a whole lot about his brain injury. You do that, he's going to swing a punch at you. He's going to start throwing punches at you because you're insubordinate or you're telling him what to do and you're not. He's the commanding officer. Like, we had all that stuff. But then after that period of time, his mom brought pictures in of his accident. We were able to start to build storyboards of what happened to him and start to bring him into contact with the realities of where he was and what had happened to him. And then start to educate him. And then you start to see learning, because then you get a little bit of buy-in. It's like, oh yeah, I had this accident, so I need help. And I need help because if I don't, I might get hurt again. And that's like very simple linkage to something more complicated that's kind of like awareness, acceptance, and adjustment. Speaking from a psychological side, like, guys have to be aware of what happened, and then before they can then work on accepting, like, okay, now my life's different. And then they work on
Sure.
adjusting, like, so that means I now have to do these things differently.
Yeah, I try to explain it to a lot of people because I've had several that had clients, consumers who had some level of delusional behavior or just confusion, and often it's, drug or medication induced. You talk to them afterwards, and they said, "You all sounded crazy, and you weren't making any sense. It sounded like nothing was going on. I was the only one making any sense here." And so there's no reason to try to reorient somebody in that situation. You can either, like you said, just appease them and bring up something based in reality and hope they join you in that, or just kind of let them go on until they're ready. So
That's exactly right.
And
Yeah,
that's where
living.
language complicates all of this, right? Like,
Mm,
and that's something when you're working with little kids who maybe don't have language, it's a different ballgame. But when you're working with adults who have language, it's different. It's different.
um, I wanted to move on to the stability triangle because I was really interested in reading this. What is the stability triangle, and how does it kind of guide treatment? This seems like it's a very collaborative, cross-disciplinary effort in treatment of these behaviors and injuries.
Yeah, the thing is, right, the thing with the way the triangle emerged, Kyle and Steve, was it really, when you come into brain injury, and as some of the guys we were describing already, like, you have these clients who are coming into our facility brand new to us, and they're coming out of acute rehabs. And when I started in brain injury in 1995, people were spending 6, 9, or 12 months in an acute rehab hospital. So we saw very few tubes, and a lot of swallowing stuff. A lot of things were already worked out. Well, as we know, the sort of landscape of insurance has changed. That's now, it then went from 6 to 9 months to 6 to 9 weeks, and now it's somewhere like 14 days. And then people are coming out. And so what we had to do was we had to become more and more familiar with, like, say, the inside story, because those things weren't as resolved. And what to me that meant behavior analytically. Now I'm a little bit of an older guy. Like, I remember reading about Skinner setting events, and then Jack Michaels establishing operations before it really evolved into MOs and as it's structured now. But my takeaway from that, especially when I was studying for my exam or reading all the things that Heinlein was giving us, was status of the organism. Right. If I just think about it in terms of the status of the organism, is going to affect all relations that follow. It's going to affect probabilities of behavior because it affects values of reinforcers, like in the simplest terms. And this organism is not the same. And these MOs are not stable. They're not sleeping. right? Their sleep is disrupted. They have pain that's not managed. They had pre-existing substance abuse histories, and now maybe they were significant. Now they're dealing with cravings, and they're managing cravings. Maybe they have something called a vestibular disorder, which is when you fall and you have these sort of like little tiny crystals deep in your inner ear canal that regulate your your proprioception and your sensory perception. Those get disrupted in falls and sort of traumatic brain injuries. Now you feel like you're like on a boat, or you're seasick, or you're drunk and spinning. That's how it's been described to me. So if you're feeling any or one or more of those things, guess what? Like, all the stuff I think is important is not important to them. And it
Yeah.
also dysregulates their behavior because they're coming out on stimulants, or they're coming out on SSRIs, and they're not on mood stabilizers. Or worse, they're on benzos. And they're on benzos because they're punching people in acute hospitals. And now the benzos are polluting their cognition, right? And cause them to rebound and freak out and yell at people. So we got to get them. And this whole wash that's happening is happening in real time in our setting. Right. And sessions are short because they're screaming at therapists, and they're leaving, and they're
Mhm.
coming back in saying, what do we do? So we understand behavior analytically that we have to get to those things first, which is why at the top of that triangle is medical stability. That doesn't mean it all gets done and we're all sitting and waiting. It's just we have to have some vision of what that is, and who's going to do that, and how that sets priorities for everybody else. And those people need data to drive their decisions about medication trials or other types of interventions. So we have to, as Christina said, we have to arrive at some definitions of what we're looking at so we can provide those data. And that's why medical stability is at the top. Because
Mhm.
if we don't do those things, we're violating the seminal formula of our science. We're not attending to MOs, and we're just acting like behavior should happen because we think it should, or that something should be important because everybody thinks it's important. It's like, well, that's not true in real terms. Christina, do you have anything to add about medical stability? I don't want to just keep going on about it. I could just keep talking
Oh,
about it.
yeah, like I think for me, we were working, you guys came up with the stability triangle, before my time, and then we just sort of worked to, see how kind of how to integrate it and explore how to also use as a tool to like frame the team. For me, I think what really hit was one year Craig Kennedy came to ABAI and did a talk on health issues and MOs. And I don't know if you guys are familiar. I personally think this is one of the most important papers. I assign it to every cohort of students I ever work with, and I give it to every clinician. But Craig Kennedy wrote this paper, Health and Problem Behavior Among People with Intellectual Disabilities. And basically, what they did was they took kids who had intellectual disabilities and a history of self-injurious behavior, specifically headbanging, who also had chronic ear infections. And they would test to see if they had an ear infection, and then they would do an FA. And they did two conditions. They did an FA on head hitting with an ear infection, and an FA on head hitting without an ear infection. And what they saw was the results of the FA were different. So if
Mhm.
you think about it, that's one factor. If you now have this multitude of factors, the MOs are all over the place. We
Yeah.
see, and I remember in that Craig talked about some of the factors that most likely are going to influence behavior and behavior relations. And he talked about pain. He talked about constipation. He talked about sleep issues. Um, you know, all of these, even going back to some of Jack's, initial writings on MOs, he talks about basically everything that's on the list of symptoms following a brain injury. So it makes sense that learning becomes really, really tricky, right? And that teaching becomes really, really tricky. And so I think ultimately the wisdom of this triangle is that at the top we always have to consider medical stability. And then in tandem, behavioral stability and stable activity plan. And one of the things I really like about the triangle is that there is this assumption that those things can't happen in isolation. So you can't then, get medical stability, work on behavioral stability, and then send someone out into the community with nothing to do. Because they've now
Mhm.
lost their job, most likely. They may have lost a bunch of their friends. They may have lost their role, even, as, say, a homemaker. Maybe they're not able to take care of their kids anymore. Well, you're not going to maintain behavioral stability and you're not going to maintain medical stability if you got nothing to do. And
Right.
after a brain injury, there's a lot of nothing to do. And so that's one of the things I really like about that triangle. And I can honestly say that in my time working with Chris clinically, I don't think there was ever a case in which it didn't apply or we didn't go back to it. Even if I was working with a guy who had been in rehab for 20 years, I could still go back to that and say, okay, where do we need to prioritize here?
Because you're talking about MOs at the top, ostensibly, and then skills in the cognitive and behavioral section. And they're talking about reinforcers on the
Yeah.
stable activity plan side, right? Is if we're really looking at a broad lens here. Because these people are, especially the ones we saw in this intensive neurobehavioral setting, they were more on the sort of either persistent chronic side or really complex and significant side. So both of those things had a significant impact on what these people were going to do all day. And luckily, the company I grew up working for there were tons of TRs everywhere, and all they were worried about is what's this guy going to do all day? Like what?
Mm.
Not just with us, but when he goes home, he can't drive, can't mow his lawn, can't go to work. Okay, guess what? I do all three of those things like every day of my week, right? And now if I can't do those things and I'm brain injured and I'm impaired and I have mobility issues or I have vision issues or I have, I can't manage information effectively, like you're talking about a real complex world that has to be constructed for this person. So, and the other thing is that the other part about the triangle in general too, to make here, Kyle and Steve, is everybody comes to us to say, this guy won't meet with me, this guy won't do this thing, and he won't keep doing it, he da 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 da. Everything flows back into behavior. Well, every problem that anybody on the team is encountering is a behavior problem, right? We know
Mm.
that it's some challenge associated with, more or less of some behavior. And so when we do that, the triangle becomes sort of like this foundational component that everybody can work inside of. And so at the top, we say medical stability. Well, what does that mean? That means we have a neuropsychiatrist and a physiatrist who are looking at the whole organism. The physiatrist is looking at things like tone and spasticity, we've all had a Charlie horse or some kind of little muscle, like when you're laying in bed and you stretch your foot, your sort of arch grabs. It's like, oh man, and then you're
Yeah.
trying to work. Well, imagine being in a bed and that's happening uncontrollably and unpredictably, and you can't fix it. And someone's coming in to do some kind of cognitive task with you, which you're like, get out of here with that. And that's the really
Yeah.
nice way of saying it. So you've got to have these medical people that are treating those things with like a spasticity we treat with like baclofen, for example, or if someone's really struggling with a lot of, upset and anger and dysregulation in their mood, you need mood stabilizers on board. So you need those people. And if they have vestibular issues, you need your PT. If they have bowel and bladder issues, you need your rehab nurses working on bowel and bladder and food and fluid stuff. So the organism is stabilizing. And then what you're going to get, and I can't go further without nodding to Phil, because the other linkage to the stability triangle, guys, is Phil wrote an article when I'm trying to reference here in 90 called The Origins of Environment-Based Psychological Theory. And it was really about the language and the need for our language in describing behavior to be tripolar, because behavior is the product of the interaction between the organism and its environment, right? And so what we have are experts in the environment, us, and then we have all these experts in the organism sitting at the table. And we have to bring those things together because they're all influencing and impacting behavior directly. So we have to try to organize all those things on all these levels. So if we say someone's not stable medically, it means the rest of us are kind of still involved, but guarding our expectations until that little turn starts to happen. And that
Mm.
learning shows its face, looks like I was just telling one of our other BCBAs here this morning, that looks like discrimination or differentiation of behavior across settings. Like you start to see that stuff and it smells like, okay, now they're attending to the environment. They're discriminating stimuli, right? And we're getting some of this differentiation.
I love the connectedness. I feel like so often, at least in our line of work, we hear, and again, this is not specific to acquired brain injury folks, but just the folks we work with. But we hear kind of secondhand, like, "Oh, there's been a medication change," or like, "Oh, but yeah, he started a new PT like 6 months ago," and you're like, "Wait,
Uh,
when did that happen?" And yeah,
Not even that, but hearing you talk about like the behavioral versus non-behavioral, and for everybody listening and not watching, and I'm doing the air quotes because this person wanders in the traffic, but that's because they just don't have the skills. That's not a behavior issue. Versus this person is trying to attack other drivers driving by the house. That's a behavioral issue. I'm like, just
based on
let us
real
design it
events.
for both, please. Just let us intervene.
Let the behavior people. And like what Kyle said, I don't know how many articles I read where in the footnote it says, oh, during this study, like 3 medication changes occurred. And I was like, oh, you don't say. Because what
Yeah.
Christina was talking about, the Kennedy article, I was given a talk one time and it was at a place that was doing intensive FAs for really intense behaviors. And this guy came up to me at the break and he said, hey, Chris, like we were doing an FA the other day of head banging. Like, should I be thinking about changes in the organism during the FA? And I said, hey, buddy, if I punched you in the face right now, would it change our conversation? Like it would change, like things in the environment change and the organism changes and behavior changes. And of course, we were laughing about it while he's like, because he knew exactly what I was saying. Like if I walked across the room and banged my head, different things become important to me immediately. And therefore different behaviors become more probable immediately. So all of this stuff in brain injury is real time and kind of got to roll with it, and be aware
Yeah,
of it as much as you can.
very similar situation I'm doing now. It's a case that had national attention because of how severe the self-injury was. Many years ago. I came in years after, and everything was going very well for 7, 8 years. Now all of a sudden it's coming back, and we're like, looking into it, turns out there's a large mass in the abdomen. Well, of course, there's going to be some discomfort there with whatever else is going on with this. It's removed, and then 2 days later, they're wanting to discharge and expect everything to go back to normal. I'm like, oh yeah, you just feel fine 2 days after surgery, huh? You're just good to go at that point. Like we don't know what
That's
we're
the
dealing
medical
with
model.
for a few months now. In a few months, then we'll look at this and see what we can figure out. But for now, we don't even know what we're dealing with.
Yeah,
Absolutely.
right.
Yeah, absolutely.
And
And
Christina did it. Oh, go ahead, please. I was going to set you up for the question, but yeah, go ahead.
well, I was just going to say, having done this long enough, like my first thing is just like, oh man, there's going to be constipation because of those pain meds. I mean, like,
Yeah,
Right.
yeah.
those are things that we got to be thinking ahead, Yeah. What were you going to say, Chris?
Oh, I was going to say, you've done some really nice work. I was going to say about in terms of like being a BA on a team like that, it takes a lot of work to be seated at that table because every other expert at that table has had a neuro rotation, as a part of their training. Any OTs, PT, speech, they all go through some neuro acute rehab setting, whereas we don't. And Christina did a lot of work for a lot of years of like how to be a BA on a team because it's a different kind of a thing, right? We're not really trained that way. We work very well among ourselves, but when we have to go out and translate things to the other worlds, it gets complicated. In this world, we can't go this alone whatsoever. So
yeah, when someone joins our team from a traditional autism setting and they're coming from a situation where what does the family want? What do they want to key in on? What are we going to do to make them have the outcomes that they're looking for versus now we're talking about the most severe behavior in the state. Sometimes you have to teach people to be the expert in the room rather than just listen to the other experts at the table.
Right.
Yeah. I wanted to move toward, and again, I've got a couple questions that we said ahead of time. Some of these I feel like are kind of, they could go in tandem. So I have this question: what does behavior analysis kind of bring to the table in this domain? But I think a good counterpart to that question is, folks who maybe aren't familiar with this demographic when they're doing things like their functional behavior assessments and functional analyses and things like that. What parallels work with like typical autism work, and like what would be something that like, hey, you really need a lot of mentorship and training in this area in order to do FBAs effectively with TBI?
Absolutely. Yeah. So, I had the opportunity to go from, a standard early intervention model into brain injury. And um, a couple things. Um, there's similarities, right? So skill acquisition, and I actually think that those skills translate really well into a brain injury setting. What is different though is in a brain injury and rehab setting, people look for you to be the behavior police, and they forget that skill acquisition is necessary, particularly if we're going to extinguish something. We need a replacement. And so one of the things is you have to always remind people, like, no, actually, skill acquisition should be most of what I do, and I can do it. Behavior reduction, obviously. There's tight timelines in the same way that there are nowadays with autism treatment and insurance. And those timelines in brain injury sometimes are wild. I mean, we would have an admission for 30 days, and the person would be like us or jail. Fix it in 30 days,
Yeah.
So crazy tight timelines. Um, and there's also this whole kind of like fitting around peg in a square hole. So there's still treatment plans, there's still goals, and you still have to fit your science into it, right? And maybe even more so, no, definitely more so than in autism, I would encounter the situation where someone would say, like, okay, so, you have this referral, the individual becomes aggressive every time caretakers at home ask him to shower. So he's going to come to your office every Tuesday and Thursday from 2 to 3 p.m. for therapy. Okay. And you're like, that's not going to work.
Not how this
Like,
Right.
works.
what do
Right.
you mean? It works for OT, it works for PT, it works for speech. That's our model. You got 2 to 3 p.m. What's the problem? Um, so that's definitely a barrier. Um, difference is there's even less tools for assessment than there are in autism early intervention. I mean, right now that field still sucks in terms of our real tools for assessment. Brain
Mm.
injury is even more of a wild west. Um, there's differences in the way that your stakeholders are involved. So sometimes there's family members involved. But most likely, if somebody's inpatient or they're in long-term rehab, those family members are probably not primary caregivers. Instead, the people who you're probably going to be dealing with more so are staff. So you're going from a parent training model to a staff training model, which is very different. And then overarching, there's this big, there's a big difference. And I noticed this right away between rehabilitation and habilitation. So I was used to habilitation. I was used to my kid doesn't say anything. Now my kid works with you and now they say words and we are thrilled. And we're taking videos and we're sharing with grandma and grandpa. That's very different than, I remember one of my first days I walk in and there's this 35-year-old guy who's like, I had a job, I had a house, and I went to work every day. And now I'm stuck in this hospital. So are you going to get me out? I was like, whoa,
Yeah.
and all of a sudden for that guy to shower independently, he's not happy. His family's not happy. No one's happy about that, right? I'm happy. I'm like, dude, you haven't showered on your own for 6 months. And he's like, yeah, I'm supposed to be at work behind my desk. Like, this is not a win, you know?
Yeah.
So there's also just size and stature, I mean, you're talking about grown adults. And when you have the level of self-injury or the level of property destruction, it's different. I mean, there's dressers, there's furniture being thrown,
Hmm.
it's different. Um, there's dealing with loss, grief about loss, and all of that. And then ultimately, there's just this interdisciplinary team overall, and that could be a whole nother conversation. It's a training that I give, but really, there's figuring out. Chris alluded to this, but in other fields, there's rotations. There's also in other fields guidelines and training on how to do interdisciplinary work that we don't have. So like if you go into the code of conduct and the guidelines for SLPs or OTs, they have actual guidelines of interdisciplinary work and we don't have that. So I think that's the biggest thing that you really need to sort out how to work on a team.
Chris, any follow up to that?
No, I mean, it's critical, Kyle. And the way I've started to couch it more recently is I come in and try to say a BCBA can primarily do two things. They can expand neurorehabilitation by having this very focused behavior analytic lens on treating some of the most aggressive or challenging, like elopement behaviors or aggression or all these other. We can do some of the high flying stuff, but also we can saddle up and enhance what other people do. So like collaborate with a speech therapist on a swallow. They know all about dysphagia and the mechanics of a swallow far more so than I do. But when
Yeah.
someone's just shoveling boluses of food in their mouth and your only recourse is to stop them from doing that with your hand, and then they want to flip the plate, the speech therapist has usually left the room, and they have great fortitude. I don't mean to speak badly about their constitution. I just mean to say to them, unless they've had some experience with that, they're not quite sure what to do next. Right. And so whereas we come in and we look at it like, okay, let's start working on this. Let's structure it this way. Let's work on reinforcement here. Let's do a blocking procedure, something, and make it very sort of procedural. I think we can really, and whether that's that or it's the PTs trying to work on somebody on mobility safety and they won't stay in their chair, or they have to get, an OT has to get through a shower sequence, but they can't. I mean, I've given guys showers with wore my fishing waders into work sometimes because it's just a total Gallagher show. Like everyone's going to get wet, everyone's going to get soapy because there's all this aggression happening in this like horrible environment where everybody's wet and sudsy. And you just have to like really like ride along the therapist in that, like co-treat, I guess is the way to say it. So there's either you come in as your, you can do your own thing on the, you can also, and the data that underpins things, and then the staff training that we have available to us in I mean, those are powerful tools to bring to a setting, regardless of what you're actually targeting or working on. Those things can benefit everybody.
I laugh because everybody at the company loves the story of how my nice blue suit got covered in peanut butter, because in the midst of, we've established this is the reinforcer, we deliver the reinforcer, and this is an adult with zero verbal behavior capabilities, really no previous training, and this says nope, that is no longer the reinforcer, and so I just covered in peanut butter.
You learn pretty quick.
Yeah, that's it's part of the job, Steve. It's part of you just gotta, and then at the end of the day, it's hilarious. It's like ridiculous stuff that happens that people say to you or try to do to you or call you or whatever. They're going to fire you. They're going to sue you.
Yeah, I still
insane.
I still love when someone from the community mental health department lets me know that there's a death threat against me. I'm like, I gotcha. Don't worry. You don't even have to let me know. It's all good.
Line them up.
It all works itself out usually.
I'd also like to point out we've referenced Led Zeppelin and Gallagher in this episode. So if we haven't lost the kids yet, thank you guys for sticking out this long. I dig
well,
it.
Nickelodeon with the slime. How's that? We could kind of try to update it a little bit. So
slightly more in the 90s there. Hey, we're rounding up on an hour. I've got so many more questions. I like in the paper that she gave me and in your book chapter, big focus at the end, especially on dignity and respect. You reference an end goal of not behavior management per se or controlling the behavior for behavior's sake, but of community integration. Can you kind of talk about community reintegration, and what that looks like for, if it looks, different with somebody in this population as far as in terms of restrictive environments or, ongoing supports?
Yeah, absolutely. So I think that for us, that's always the goal, right? And the way is, it's kind of to optimize, like enhance and optimize an individual's life, right? Circumstances. So when they come into our setting, like Christina was describing, and they're confused, we're hanging in there until we're addressing factors that are contributing to that confusion, right? And then we're trying to more fully. So a lot of times around that admission period, we're stabilizing somebody. And evaluation treatment hasn't even really started yet, right? Because we're just stabilizing until we get relations settled and we know we're going to get some predictable responding. And then you get sort of more true to form of valent treatment phases. But then, as we know, it's all about generalization and maintenance. So we have to do that in the setting that we're in, but then we have to think about, and by the way, these people that we're working with, they're not sitting around like, oh, tell me when the next thing happens. They show up and say, Schaub, when are you going to get me a job? Like, I'm supposed to be home. I need to drive my car. I need to, like I said, mow my lawn. I need to work. My family doesn't have money. They're urgent about these things, or they want to live in their own place. And it's like, okay, I'm hearing you. We've just had a preference assessment interview, right? You're telling me what's most potent as a reinforcer, but man, talk about delayed reinforcement. Those are very large, but very later reinforcers. So what and this is where we just like supercharged it when Christina got there, because we started to have to deal with these guys who wanted to live in an apartment. And we start looking at the triangle, like, how do we start moving through here? And we look at the team and say, what does everybody think is necessary? What are the prerequisite skills for us to say yes? Like, they need to be able to manage their money and do a little food shopping and a little cooking and a little food prep. They need to be able to manage their room, and they need to be able to manage their laundry. They need to be able to manage their medication. So what comes from this little exercise that we have almost Socratically with the team is this list of repertoires. Right. And then it's like, okay. And before we can do those things, you need to stop punching people, or you need to be able to shower more than once every 3 weeks. So they're telling us what they want. And we're saying, well, here's what we need to do to get there. But it can't be that if you do all those things for 3 months, we'll try an apartment and see how it goes. Like, that's a ridiculous plan. So we have to start with things like, okay, right now you're one-on-one in the community. because of these reasons, because of safety features or ambulation features or whatever that is, or we can't get into the community because you're, aggressive, or you won't shower or won't take meds, all these things that are happening. And we try to, basically look at those things as contingent relations and say to them, if we want to, you want to move out on your own, the first thing we need to be able to do is have you be safe to be in the community. And then you have to be safe in the community with more than just me and our intrepid RBT group. And then if you get to that, then you could go to small group, and then small group, you go to, and these little pathways emerge. And those little pathways are ostensibly reinforcers, like conditioned reinforcers, meaning those changes in access become conditioned reinforcers for the ultimate change in access, which is getting out of the residential setting. And we start to build out those phase plans, Kyle. Like, that's where those came from. And Christina was just such an expert collaborator on these things because they're so complex. But again, like the triangle, we're looking at the contingent relations, kind of the matrix in the background, while the therapists are telling us what the goals are and what the treatment areas are. And then we're working with the client to kind of build out their progress and data collection with them and how they're doing, and really to see. And then when they get out into the community, it's all capped by their own performance, meaning to say they're going to go as far as they're able or willing to go. And if they can't do something that they still say they want to do, like say drive or work independently, I have a whole bunch of data and sheets that say, here's why we're where we are. Here's why we're not recommending work for you. Here's why we're recommending this. And if this can change, great, then we can come back. One of our lines is make it impossible for us to say no. I hate the word never. I hate the word never. So I very much prefer like not now versus never. Never is not a great rehab word. It might be not now. And forever is a terrible rehab word. So for now is always, it's like, look, this is just for now. It's not forever. So let's just do this a little bit here, and then we could try to get to these other things. But it's all readiness based.
And these plans have been in place for individuals for years and have helped to keep them stable for years. And I mean, it's incredible the nuance that goes into planning them. I mean, even just something like even just outing. So, Chris talked about like with what staff support do you need, but even like independent outings, like, and this is where I think sometimes I was able to bring some of like my autism experience, like close-ended activity versus open-ended activity. Going to a movie in which staff can send you in and can hang out outside and we know you're in there and then you come out at an appointed time is different than spending 2 hours at the mall. It's different than walking in the community for 2 hours where you have access to 2 bars and a liquor store. I mean, those things are all really different. And those are the types of things that we would put into these phase plans too, like level of access, level of risk. So it's a
Yeah.
really, really helpful tool.
I think it mirrors a lot of our consumers too, where, that they're in a restrictive setting in the sense that they have, community supervision, or, they're at least in a group home or something like that. They get very involved sometimes in their phase plans. They really want to see what it is, and even have a voice in what criteria when. I remembered like reading about, I love a good phase plan, and I feel like our organization does a really good job with these, but I remember having a really spirited discussion with somebody's guardian who wanted a pretty conservative phase plan versus the consumer himself who wanted a pretty forgiving phase plan, and is finding that medium like road, like, okay, like I get what everybody's saying, but we do have to make it possible for community integration to occur, but we also need to make sure that you're not going to go punch somebody when we do it too, so
Yeah.
I love a good phase plan.
I've started describing it more of a roadmap than a behavior plan. Like, this is the roadmap to get you where you want to be. And then for those concerned parties that don't know that they want them to be, they're like, listen, if they get there, then we won't have an argument anymore. But they may not reach the end of this map. It's just, this is the way to get there, and we'll get as far as we can, sort of.
And the interesting thing about awareness as it collides, sometimes coalesces, but often collides with these plans is, when someone's really profoundly unaware, and that could be a chronic refractory feature of their injury, and you have someone saying, I'm still able to do these things, and everyone else is saying these things aren't safe. Ideally, this rehabilitation process includes some level of insight building, right? Developing, and we can't get it. Christina built this beautiful curriculum around what we called functional trials, like really exposing clients to discrepancies between what they say and what they do, and doing that
Oh, cool.
systematically and programmatically, so we can sit and debrief and wrap up with them and orient, and really literally we call it like mine for insight. Like, hey, listen, we know this is what you said, but this is what really happened. Let's, like, we might even watch it on video or listen to it on recording, right? Because what happens is, to the extent that someone can become more aware, they can become much more collaborative and self-directed. There's a whole awareness pyramid that preceded our stability triangle, right? That's about intellectual and emergent and anticipatory. That came out of the brain injury literature in the 80s. So if someone gets through that, they become a good candidate for self-management. But we've, like Christina described, we've got a number of folks who don't get there and think it's all stupid and ridiculous. And the only reason I show up for work is to steal their money. But they know if they follow these rules, they can move into an apartment. So I might show up and say, hey, what's up? And they say, they
Yeah.
tell me to stick it because they still don't like me because they're following my rules. I'm like, okay, but you're living in the apartment. You got out of the house. Like, that's what we were going for. But they still
Yeah.
don't understand the reason or rationale behind it. And sometimes that's like a little way to treat awareness. It's not ideal, but it's possible.
We tend to have a little bit more trouble with it when it's a mental health diagnosis rather than brain injury. And
Right.
say, some of the diagnosis of schizophrenia, trying to get them to be on that same wavelength is not always as easy, but
Right. That's exactly right. Because that's a very different sort of phenomenon, Steve. Right.
right,
Exactly.
right.
Winding down here, questions, further research. What do you see the need for going forward in terms of the research and in terms of the current state of affairs with respect to behavior analysis and brain rehabilitation? What where are we at, and where are we headed?
Yeah, yeah. So, we joke that when we started, it was the Wild West, but it's still the Wild West. That's the truth. But there's more people headed out west, and so it's an exciting time because I think there's a lot of people who are now interested, a lot of people getting involved, and there's just we're at an amazing point at time to get involved because I think this is really the beginning of something great. In 2014, our colleague Megan Heineke and Jim Carr conducted a meta analysis looking at single case research in brain injury. Basically, what they found was there wasn't a lot, and what was there wasn't done with the highest of quality. And so, as a result, at least according to the APA Division 12 criteria, there was only like 5 interventions that could be considered well established. Like reinforcement, antecedent variables, differential reinforcement, antecedent intervention and punishment, and that's it. So, like behavioral contracting, no, considered experimental, right? So we need to do research, and it's not even like we need to do fantastic research. We need well-designed studies on simple interventions. And so this is like an amazing time for grad students who need to do a thesis or dissertation, for early career professionals, professors who need a lot of publications. Like it's an amazing time to do some basic research in this area. One of the biggest barriers to getting that research done has been having enough PhD level individuals associated with universities with populations of students who need to do research or interested in doing research, have the resources, the IRB, et cetera, with
Mm,
those clinics.
mm,
And what we've been sort of working on in the background is getting that together. So, the BACB did us a huge solid a number of years ago, and they got a group of us who are interested in behavior analysis and brain injury together, and they assigned us to a professional to kind of do a strategic planning, which was amazing, and we did, and we've been following that plan. As part of it, one of the parts of this project or an associated project was putting together a respecialization guide, which is available on the BACB website. So it talks about if you're a clinician and you want to get into brain injury, here's what you would need to do. And then we've done tremendous amount of work. Chris has been the president of the Brain Injury SIG this last year, and I've been a member of this group forever, and I've never seen as much growth as I have in this last year. Chris, I
mm.
like it's amazing.
It's been great. Yeah, it's been fabulous.
We've got this core team of people who are interested and engaged. We've grown our membership base. We're putting together a website. We're putting together a newsletter. We've got a lot of events at ABAI. And so I think the wheels are in motion. We put together this research special interest group. We get together once a month. I say it's open to anyone who is interested in doing a research study in the next year or interested in reading their first research study in the next year. And I mean it. Like, we have people who are in it and who have done this work for years. And we have some of my students who have maybe read one article and
Yeah.
we just help each other. That's it. We just, hey, I got an idea. Would this work? Would that work? What if we try this? Maybe you could publish here. Oh, you want to do research in your work environment. What are you interested in? Where do you start? So we need more research. We need more people who are interested, but we finally have some outlets. So the Brain Injury Special Interest Group through ABAI is booming. I encourage people to contact us, get involved. And then also any faculty member or clinician who wants to do research. We're at this point, I feel like we're sort of trying to become the online dating app between clinicians and researchers. And we've got a good Rolodex of both right now. So if you're on either one of those sides and you want us to do some matchmaking, let us know.
Yeah.
Perfect.
Yeah, I think we would definitely want to shout out the SIG, Kyle, and we don't have an official website yet. That's in motion. But if people just email Christina and I from this,
Yeah.
that's the gateway right now. And I was just looking at the BACB website this morning, and of 84,000 registered BCBAs, that's, I think, the hedge. It's 83.5 something. 0.06% identifies brain injury rehab people, which by quick calculation, thanks to Gemini, is 50 out of 84,000 BCBAs, right?
Yeah.
So, and 80, what do I have? 70,000 of those 84 work in autism. So, and like Christina's saying, we've now got this SIG that has this, just like beautiful embers, like it's cooking, it's starting to like heat up. There are practitioners, some of us like that have been in it a long time, some that are brand new, but people in the field in settings, right, with subjects, whether that's acute care hospitals or post-acute settings like ours. And then we have these students and faculty that are coming into the SIG. Like we've got Christina, we've got Allison Cox, we've got April Becker down at UNT, we've got Megan Heineke, as Christina mentioned. I know I'm forgetting some, but we've got these universities who have students, like Phil did at Temple. He had students, and they actually, because we were so proximal to Temple, they would bring a class of students out once a semester. We do a site visit, and I would introduce them to some of the guys, and they would tell their stories. And it was really just powerful, personal things. Because when you start talking to people about it, almost inevitably, someone's got some connection to a family member or a friend or not sure what's happening with their parents, maybe, or something like that, whatever. And they share maybe some kind of personal connection, or they have this intense academic, curiosity about it and this appetite for this literally all you can eat buffet of behavior that is brain injury. Like it's all over the place. And so regardless of and there's just people that you'll learn from, regardless of whether you stay there very long or not. You'll learn from these other team members. And most importantly, you'll learn from the people that you're working with and their spouses that come in to visit, or their parents that come in to visit, and how it's changed their lives, how everything has changed. And one Christina, can't leave this podcast, Kyle and Steve, without sharing one of Christina's famous lines was, "It's both a privilege and a burden." Right. The privilege is being in this space with these people that's so personal and so intimate, so profoundly tragic, that they're sharing it like you're there to help them. You have the privilege of being in this position, but you bear this incredible burden of they don't know what to do, but we're supposed to. And my line for our guys is, look, if not us, then who? Like we have to be the experts in the room, back to what Steve said earlier, like, let's go, we'll figure it out, or we'll go down swinging, but like we have a science that's hard and we can bring to this fight, and it can be all inclusive. It can bring everybody in. And I think people on the SIG are starting to feel some of that energy, and the students that are just curious, they've just heard about it. They're feeding off of the experience. And a lot of us want to mentor students, get them into our settings. There's some things we're working on internally, whether we can go the routes of stipends or somehow fund students to do a little bit of travel or stay with us over a summer for 4 or 6 weeks, something like that, or even just come and visit a setting of ours. And Maybe if they're close to one of our sites, we can work together. We're talking about that with Christina and some of her students. So we're really trying to get people in, and also bring the science out, bring our science out to them.
Right.
ABA,
Right.
Yeah.
ABI.
As much as we see people, at least on Facebook and other places, talking about burnout in the autism centers or not liking the work, is this field right for me? I hope that is an opportunity for them to see these other opportunities in our field and not just think, you know what, behavior analysis isn't for me.
Right. That's right.
I
That's
agree.
absolutely right.
One of my most well-attended talks I did with a group of colleagues at Calava, and we just entitled it "Sick of Autism?" And
Yeah.
you
Yeah.
filled the role, and
Yeah.
there's nothing wrong with that. It's work I've done, I've returned to, and I feel passionate about, but there's a lot of outlets here, and there's a lot of places where our science can and needs to have an impact, and this
Mm.
is one.
Yeah, I found about a year and a half into my master's that it wasn't for me and had to find a different route to go. So it was fulfilling work, but I couldn't get in those little chairs anymore.
Sure.
So.
Yeah, it's noble work. It's good work, right?
Yeah.
So
I would love to see video footage of those interactions, Steve, someday, but
They're out there.
Hey, this has been such an amazing kind of crash course in brain injury and behavior analysis. We'll be sure to include contact info on the episode notes. If anybody is listening and is like, I want to know more, or put me in contact with who I need to talk to, we'll have that information in the show notes. Christina and Chris, thank you so much for joining us, taking the time to go over your years of knowledge with us. And this has been another episode of Cooperant Learning. Thanks everybody for tuning in.